I'm Tonya. I'll be your nurse practitioner today. How you feeling?
Feeling well, thank you.
What brings you in today?
I'm here for an annual well visit.
Annual visit. Okay. So, general overall appearance, she's looks appropriate. She's speaking appropriately. She's answering in a timely manner. So we're just going to start with some common questions. Okay. So can you tell me your name and date of birth?
Jen Sitneri, 3372.
And can you tell me the year?
1972. No, 2017.
And can you tell me the president?
Donald Trump.
So she answers in a timely manner as stated. She's keeping eye contact. So right now everything's all appropriate. So I'm gonna just have you follow some simple commands. I just want you to complete what I ask. That way we can move on. So we're going to start with a neurological assessment, and then we're going to move to abdominal, and then we're going to move to musculoskeletal. Okay? All right. So I'm going to have you smile for me. Stick out your tongue. Move it side to side. Squint your nose, and puff out your cheeks, and raise your eyebrows. Okay. Good. Shrug your shoulders for me. Okay. Arms out. Wiggle your fingers. All right. Turn your hands rapid movement. Good. Hand palms up. Push up. Push down. Good. Squeeze. Good. So strength is 5 out of 5. She follows commands. I want you to lift your right leg and lift your left leg and lift them both. All right. Push down. Okay. Push up. Good. Okay. So right now we're going to do some cranial nerve assessment. So we're going to start with the optic, which is number 2. So I'm going to just shine a light in your eye, okay? And I'm just going to look for reaction to the light. And she has positive correlate. So we're going to do cranial nerves 2, 3, and 6, which is oculomotor testing. So we're going to do the 6 cardinal gaze. So I just want you to follow my finger with your eyes, okay? Ready? We're going to test for convergence. Good. All right, so now we need you to touch my finger. You're going to touch your nose, then touch my finger. So you ready? Touch my finger. 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 And finger. Good. So we're going to do, I'm going to test your peripheral vision. So that doesn't just bring my hands from behind your head. Just let me know when you start seeing my fingers, okay? So we're going to do the whisper test. So I just want you to occlude one ear, and I'm going to whisper something in your ear. I just want you to repeat what I say, okay?
Mom.
Right by the ear.
Dad.
Good. So we're going to do, I'm going to place some items in your hand, and I just want you to tell me what they are, okay?
Okay.
Close your eyes for me.
Paperclip.
Okay.
Coin.
Okay. So I'm going to draw a figure in your finger. On your hand, and I want you to tell me what it is, okay?
G. Oh, an 8.
An 8, okay. So we're going to test some sensory, so I just want to tell me if the touch is sharp or dull, okay? Ready?
Dull. Dull. Sharp. Sharp. Dull. Sharp. Dull. Sharp. Dull.
Okay. So what I want you to do now, I want you to stand. We're going to have you walk for me. So I want you to walk heel toe. Good. Okay, way back. I want you to walk on the balls of your feet. Okay. And I need you to walk chin to chest. Good. Now, heels. Okay, and have a seat for me. concludes the neural assessment. I'm done. Okay, so now we're going to do the abdominal assessment. She came in for a physical exam, so we don't need to do the O cards. But if she did come in with a complaint of abdominal pain, we would do the O cards, which is onset, location, duration, characteristics, any alleviating or aggravating factors, timing, and severity. And I would have her point to the pain, being as though the patient if their pain location is better described if they point at it rather than try to describe where the pain is. So we're going to just start our assessment with an inspection of the abdomen after we drape the patient appropriately, which she is. So we just pull up her shirt to expose the abdomen.
Feel good.
So we would expect the abdomen for any asymmetry, any masses, any bulging, any abnormalities that's not supposed to be at the abdomen. But she has a flat stomach and no noticeable bulging or bruising or discoloration of the abdomen. So next we will auscultate all four quadrants for abdominal bowel sounds, and we will also auscultate the aorta framing buoy, which is not supposed to be present. Okay, so all four quadrants have good bowel sounds. There's no worry note at the aorta. So now we're going to percuss the abdomen. And the sound we're looking for is tympany, and all four quadrants have tympany sounds. So now we're going to palpate the liver to try to fill the border. We can do either the cupping method, which I'll have her inhale and hold while I try to feel, or the push method, which I will also have her inhale while I push and try to see if I can feel the edge of the liver. I will also palpate the spleen, which is on the left side. Now I will palpate her kidneys, and that's done from the back. So I will do the right one. I will put one hand underneath her back, and I would use this hand to push down on her abdomen to see if I can feel. I'll also have her inhale and hold. Let go. I'll also do on the left side, I will do the same to feel the left kidney. Inhale and hold. Good. Okay, now we'll also check the location of the liver by percussing the liver. So I will start up here, and I will listen for a change in sound, and that will let me know where the liver starts, and then I go from the bottom. And I will listen for the change in tympany for the liver. During the abdominal assessment, you can also check for GU and GI for women and men, but we'll go into detail about that examination with a later assessment.
There you go.
So now we're going to do the musculoskeletal assessment, which we're checking joint and muscles, making sure there's no deformities or abnormalities present or any pain that they're complaining of. Just making sure there's no recent trauma to cause any pain to the joints or the bones. We're checking also symmetry to make sure there's no misalignments with any limbs. And so we're just going to get started. So first we start with the TMJ. So we just feel, and then I have you clench your teeth And move your jaw side to side. And your teeth. Okay, good. So that's intact. And then we're going to move down to, so we're going to do head strength. So what I'm going to do is put my hand here, make you to push to the left. Okay, good. To the right. Good. I'm going to have you tilt your head, like to your shoulders. Good. Good. And I want you to put your head back. Good. Good. Now we're going to go to shoulders. And we would feel to make sure there's like, if she was complaining about any pain, we would do palpate the joint, whatever she was complaining about, to see if we feel anything. We would do a passive range of motion to see if that would elicit any pain. But as I said, she's here for just a regular exam for work. So I would have her shrug her shoulders. Okay. I would have her bend at the elbows, push, and pull. Okay, now we're going to do some active range of motion. So she's going to put her arms, stand up for me. Arms to the side. Now I want you to put them out. Now above your head. That's called flexion. And then we're going to do extension. So we're going to go down into the back. Okay, then we're going to go lateral. So just going to take your arm and cross over in front of you. And do the same with the other arm. Good. So we're going to see. So now we're going to check her spine. And since she's sitting, this can be sitting or standing, and we would just check from cervical all the way down to just make sure it's straight. Make sure we feel no bulges in the spine. I should just have you just stay standing. Then we're going to have her stand. And now we're going to check range of motion. So we're going to have her bend down and try to touch her toes. So that's flexion. Then we're going to do extension, which is have her lean back. Then we're going to have her lean side to side for lateral. And then we're just going to have her twist at the hip. Okay, good. Now we're going to do, and from there we're going to move on to the hip.
So I lay down.
You can. Okay, so the check hip range of hip. Assess the hip. We would look at her hip and see if it's aligned. Make sure there's no deformities. Even though she should have been standing, but I already had her lay down, so we're just going to do that later. So we're just going to check range of motion. So what we're going to do is have her lift her right leg up to the air, straight out, then her left leg. Then we're going to have her do lateral, and we're going to have her hip cross out, so adduction and abduction. Good. And now we're going to have her flip on her stomach and do extension. We're going to have her kick her legs straight up. And the other one. Good. And now we're going to have her swing her legs to the side. And this is to test strength. So I'm going to put my hands here now with resistance. I just want her to lift her legs at the hip. Good. All right, so now we can stand. Then we're going to do inspection for symmetry of the hip. So we can either look from the front or the back. Make sure the hips align, and like there's no like saying that her left leg or her right leg is higher. So now we're going to do knees. So we're going to do strengths first, since she's already sitting up. So I'm going to take her shin and tell her to push up against me. Good. And pull. Good. And now I'm going to have her lay down. I'm going to check range of motion. So I'm going to have her bring her knee to her chest. Other leg. Good. And now we're going to do her ankles. Check her ankles. So we're just going to see. And there's no deformities or anything that I can feel. So we're going to have her do range of motion. So we're going to have her swing her ankles out and take them in for adduction. We're going to have her press on the gas like she is and lift back up. Good. And toes, we're going to just have them fill out. And good. So now we're going to do deep tendon reflexes. I don't have a hammer, so we're just going to act like this is it. So we're just going to test the wrist. So we just pop here. Just go like that. Then we test the biceps, so we would just tap here, and you should get a small reflex. And then we would take our arm, hold it like that. In the passive, we just tap here and hope for a reflex. Then we do the knee. We would hit right below the popliteal, and the leg should jerk a little. And then we would have the patient lay over or just grab the leg and tap the Achilles tendon and get a reflex jerk in the foot. Our final health assessment, which are going to be the rectal exam and the male genital and prostate exam. So prior to the hands-on, we want to obtain a focus history, including any concerns or symptoms that the patient may be experiencing. Then we're going to prep the area for the patient, making sure that it's suitable with lighting, warm, make sure the area is warm, and make sure we have everything that we need in the room to examine the patient. The rectal exam can be done in quite a few suitable positions. It can either be side laying or standing and leaning forward with the body resting across the examination table and the hips flexed. We want to drape the patient appropriately to maintain privacy, and not only privacy, but to provide some sort of discretion about, because we don't know how the patient may feel about being naked in front of a doctor. We also want to wash our hands and glove up for the exam, and make sure that there's appropriate lighting in the area for us to complete the examination. So we want to, before we even touch the patient, we want to make sure that we explain step by step, that way that any concerns that the patient may have about what may be coming is addressed, and also to let them be informed about how the exam will go. And just for like an FYI, if colorectal cancer is considered, we may want to do endoscopy. So we want to inspect the sacrococcygeal and perianal areas for lumps, ulcers, inflammation, rashes, or excoriations. Adult perianal skin is normally more pigmented and somewhat coarser than that of the buttocks. So then we want to palpate any abnormal areas, noting lumps or tenderness. That's the anal and perianal. Anal and perianal lesions include hemorrhoids, venereal warts, herpes, syphilitic cankers, and carcinoma. A linear crack or a tear suggests anal fissures from large hard stools, IBD, or STIs. Then we want to examine the anus and rectum by lubricating our gloves, gloved up index finger, and palpate the anal canal. We want to have the patient bear down and place the pad of our gloved index finger over the anus, and as the sphincter relaxes, gently insert our fingertip into the anal canal in the direction toward the umbilicus. Throughout this, we want to continue to explain what we're doing so the patient knows and be aware of what's going on with the procedure. And let them also know that it may trigger the urge that they want to pass a bowel fluid, but we need to reassure them that this is normal and that they will not pass their bowels. If you feel the sphincter tighten, pause and reassure reassure the patient that this is normal, and then continue with the exam. Occasionally, severe tenderness prevents entry and internal examination. Never apply force. Instead, place both hands on both sides of the anus and gently spread the orifice and have the patient bear down. If you can proceed without undue discomfort to the patient, note the sphincter tone, tenderness if any, in duration, and any irregularities or nodules. Sphincter tightness might occur with anxiety, inflammation, or scarring. As 2S4 cord lesions can cause sphincter laxity, so consider testing the perianal for sensation. Induration may be caused by inflammation, scarring, or malignancy. So we want to palpate the rectal surface. This is done by inserting your finger into the rectum as far as possible with your lubricated index finger. We want to rotate your hand clockwise and then counterclockwise to palpate as much as possible of the patient's rectal surface. We want to note any mass with irregular borders suspicious for rectal cancer. To palpate the prostate, we want to leave our index finger and rotate your hand further counterclockwise so that the index finger can examine the posterior surface of the prostate gland. We want to explain to the patient that the examination to the prostate may prompt the urge to urinate. So we want to sweep your finger carefully over the prostate gland, identifying the lateral lobes and the groove of the medial sulcus. We want to note the size, shape, mobility, and consistency of the prostate, identifying any nodules or tenderness. A normal prostate is rubbery and non-tender. At the end of the exam, we want to gently withdraw our finger and wipe the anus, or have the patient wipe the anus, and note any appearance of any fecal matter on the glove. It's probably more comfortable to have the patient wipe their cells clean just because it's them. So just if they're more comfortable, just let them do it. For females, the rectal is usually examined after examining the female genitalia while still in the lithotomy position. If only a rectal exam is being performed, the lateral position elicits a better view of the perianal and sacrococcygeal areas. Use of that as a man, but note the cervix is readily palpated through the anterior rectal wall. Sometimes a retroverted uterus is also palpable. Some abnormalities that is possible to be found during the exam: external hemorrhoids, internal hemorrhoids, prolapsed rectum, anal fissures, polyps of the rectum, rectal shaft, cancer, and anal rectal fissure. For the male genital and the prostate exam, we also want to obtain a focus history and any concerns of any symptoms that the patient may be experiencing. So we want to gown the patient, and it could be either standing or laying supine. But when checking for varicocele, the patient must be standing. The gown should cover the chest and the abdomen, exposing the genitalia and inguinal areas, and place a draw sheet at the mid-thigh. Gloves should be worn throughout the examination, and also, we want to explain to the patient step by step of what we're doing so we can address any concerns that they may have prior to the examination. So we want to inspect the penis first. So on both the ventral and dorsal surfaces at the base and the base should be inspected for excoriations or inflammation. Pubic and genital excoriations, just lice or scabies. If present, retract or ask the patient to retract his skin. This step is essential for detection of cankers or carcinomas. Smegma, a cheesy whitish material, frequently accumulates under the foreskin. This is normal. The glands, look for any ulcers, nodules, or inflammation. The urethral meatus, inspect the location. The hypospadias is a congenital ventral displacement of the meatus of the penis. We want to compress the gland gently and note any discharge. If the patient states having a discharge but none is noted after this maneuver, have the patient strip the shaft of the penis from the base to the gland, and if discharge is then noted, have a glass slide and culture materials ready so a specimen can be sent. We want to palpate between your thumb and first two fingers to palpate the shaft of the penis and note any indurations or abnormalities or tenderness. If you retract the foreskin during this portion of the skin, replace it before proceeding onto the scrotum. Induration along with ventral surface of the penis suggests a urethral stricture or carcinoma, and tenderness suggests periurethral inflammation for the stricture. Inspecting the scrotum. We want to lift the scrotum so that you can inspect the posterior surface and know any lesions or scars. Also note the pubic hair distribution. Inspection may reveal scrotal nevi, hemangiomas, as well as STIs, including condyloma or ulcers for herpes. We want to inspect for swelling lumps, veins, bulging masses, or any asymmetry. A poorly developed scrotum on one or both sides suggests cryotorchidism. The inguinal and no any erythema, aspiration, or visible adenopathy. This points to fungal infection, which is uncommon in the moist area. Also note that the epidermis cysts are common, which are whitish yellow papules or nodules caused by occluded follicles. We want to palpate each testicle and the epididymis between your thumb and 2 fingers individually. The testes should be firm but not hard, descending, symmetric, non-tender, and without masses. Tender, painful scrotal swelling is present in acute epididymitis, acute architis, torsion, or the spermatic cord, or the strangulated inguinal hernia. For each testis, assess size, shape, consistency, and tenderness. Pressure on the testes normally produces a deep visceral pain, but any painless nodules noted on the testes raises the possibility of testicular cancer. Palpate each spermatic cord between your thumb and fingers from the epididymis to the external inguinal ring. Note any nodules or swelling. Swelling in the scrotum can be evaluated by darkening the room and shining a bright light from behind the scrotum. Hernias. Looking for hernias during the examination, the patient can be either standing or supine. During inspection, examine the inguinal regions and genitalia for any bulging or asymmetry. Palpate the inguinal hernia. You can do this by place the tip of your dominant index finger at the anterior inferior margin of the scrotum, superficial to the testicles, and move your fingers and hands upward toward the external inguinal ring, just above the lateral to the pubic tubercle. Ask the patient to cough and palpate for a distinct bulge or mass that moves against your fingers during the cough. Use the same process while checking the other side. For a femoral hernia, place your fingers on the anterior thigh and the femoral canal region, and ask the patient to strain down or cough and note any swelling or tenderness. After the physical exam is complete,